Good afternoon, everybody. It's Travis Bethel from AHI Health Home, Operations Manager for the Adult Program. I want to welcome you all to our June office hours, and wanted to let you know I just hit record. So we're recording this session, and it will be available on the AHI website training page in the near future, as well as a slide deck going out to the group after the meeting. So if there's any questions today, as always, the chat function is available for folks. And of course, you can unmute yourselves along the way as well. So we'll get into it and start going through what we got going on today. So we're going to spend some time today talking about the Health Home Business Intelligence Plan. And we have a special guest presenting today on that. We'll touch on policy procedure updates and what's coming that way as well. Health Home Serving Children HCBS audit update, touch on a NetSmart topic, a little bit on COVID-19, and then we're going to end our discussion today around the Unitas ADK Wellness Platform. So going further into our discussion today, we have special guests. I'm going to turn it over to Ann to introduce them. But it's Canton Company, and they'll be speaking about our Health Home Business Intelligence Plan. Ann?
Good afternoon, everyone. I'm actually gonna, it looks like, I'm looking at our participant list here, and I can't see if Joe and team has joined yet.
Hey, Ann, I'm on, buddy.
Oh, you're on. Sweet. I couldn't see you. Thanks so much. So everybody, I'd like to just take a couple of minutes to introduce Joe Riley. He is the Chief Technology and Information Officer at Canton Company. Joe, did I get that right?
You did.
Wow. All right. I just wanted to remind everyone that Joe and team has been supporting AHI through the SSP process and the development and implementation of our business intelligence plan. And Joe is going to kind of give us a deeper dive into how that work has evolved and kind of where we're going with it. So Joe, take it away.
Great.
Joe, I appreciate the introduction.
Joe, I'm going to stop sharing so you can pull up your deck unless you wanted me to pull it up for you.
Yeah, no, that's perfect. I can share my screen.
Okay.
At least I thought I could, but yeah, give me 1 second. I think it'll. Is that coming through for everybody now?
Yes. Yep, just popped up.
Okay, perfect. All right, folks. Well, appreciate the opportunity to speak with all of you today. Just by way of agenda, so we think we can get through most of this content in about 50 minutes. Want to just do a quick round of introductions for both the engagement team as well as the CMA representatives, although it looks like, and I think Ann, you had indicated it could be around 50 people on the call, and I think there was 31 already when I dialed in. So we might not have a ton of time for that, but maybe each CMA could elect a representative just to talk about your organization quickly. Want to give you guys an overview of the project. So this will combine two things. This will be the work that we had done prior to this engagement relative to the SSP requirements. How that work led into the work that we're doing now, which is really focused on a business intelligence strategy and business intelligence infrastructure. So we're going to level set relative to what a business intelligence strategy looks like, the pieces of the plan that we're accounting for, and then what the infrastructure components will look like as well. And then finally, we're going to land on introductions to aims and drivers. That's just a framework that we use as a firm to help to align goals and the portions or the changes operationally or the supporting factors that allow you to accomplish a goal. And the reason that we do that is because it helps us understand how to take an otherwise large idea and break it into its components parts. And then what we do relative to business intelligence is layer in the way that that supports those goals and how those pieces relate. So that'll be an introduction to that framework. It'll also provide you guys with a preview as to some of the measures that have been prioritized through the work that we've done with Ann and team, and what will be accessible to you guys at the end of the day within the business intelligence infrastructure. So just wanted to give a quick shout out to our project team. So Ann had mentioned I'm the Chief Technology and Innovation Officer, and I am serving in the role of executive sponsor for this project. The project manager is Pete Nolan. Nat, who is not on the call with us today, is our manager of strategic analytics and has an incredible amount of expertise in Power BI, which, as you guys will see through the presentation, is the business intelligence infrastructure that we're leveraging in support of your goals. Isaiah and Teresa both are supporting the project from an analyst perspective. You can see under the role that they have the same role, and that's because both of them have an incredible depth of expertise relative to health homes, its operations, and the development of business intelligence solutions to support health homes or specifically. So they've done work outside of health homes, but both of them either currently or previously were in the role of developing BI solutions in support of health home networks. And then finally, Emily, who is supporting us in all things relative to the project and is always willing to jump in where we need her. So I'll pause there quickly, Ann. It may be easiest relative to introductions. If you want to, I defer to you with the number of folks on the phone, but I certainly want to give people the opportunity to introduce themselves if desired.
Yeah, hi, Joe. What we could do if everyone is agreeable is I could just call out the CMA, and then if someone from representing that CMA could just introduce themselves. Does that sound okay to everybody?
Sounds good to me, buddy.
All right. So I'm just going to go in order here. Is someone from Alliance for Positive Health on?
Yeah. Hi, this is Renee Stevenson. I'm the Assistant Director with Alliance for Positive Health. We're a case management agency that covers about 17 counties. We cover all but one of AHI's counties. We also have other internal programs, but obviously we're the health home team right here representing.
Great to meet you.
Thanks, Renee. BHSN? I'll give one more minute. Is anybody from BHSN on? Mary, by any chance?
And I think that Mary, this is Sarah, I think that Mary had another meeting she had to be at today, so she wasn't able to hop on.
Okay, would you like to do an introduction?
Yeah. My name is Sarah Arnold. I'm the supervisor for the intensive case management program out of St. Lawrence Psychiatric Center for Clinton County. We have 3 ICMs in Clinton County, 1 children's and 2 adults.
Thanks, Sarah. And Catholic Charities.
Hi, it's Heather, Site Manager for Catholic Charities in the Saratoga office, and we offer medical case management.
Thanks so much, Heather. CDPH. We might not have anybody on. Let's keep going through our list. Champlain Valley Family Center. I'm going to scroll down the list, and if I see people, I'm going to call you out. Just saying. I'm not shy. All right. Citizens Advocates.
April's unable to speak, but I'll speak. We serve some of St. Lawrence County, Clinton, Essex, and Franklin County, both children and adult.
Thank you. All right. Community Connections of Franklin County. Do we have anybody on that would like to introduce themselves? Fort Hudson Care Management. We have a quiet group here today. I think everybody's being shy of what's happening. Glens Falls Hospital.
Hi, this is Trisha Dunham from Glens Falls Hospital Care Coordination. We have 2 kid care coordinators and 4 adult care coordinators.
Pleased to meet you, Tricia.
And Hudson Headwaters.
Hi, it's Jessica Casey. I'm the Director of Care Management Programs and Support, and we are, in addition to being an adult and children's CMA, we are an FQHC with 19 health centers with embedded care managers.
Thank you, Jessica.
Thanks, Jessica. Anybody from WWAMH?
Hi, this is Lori Bishop. I'm the director of AMH's Health Home. We have 5 children's care managers and 6 adult care managers.
Nice to meet you, Lori.
Anybody from United Helpers? And did I forget anyone? Which is totally possible.
Hi, this is Kate Barkley from Fort Hudson Care Management. We are a care management agency serving adults, and we cover Warren, Washington, Saratoga, Hamilton, Essex, and Clinton County.
Nice to meet you, Kate.
All right, is there anyone else, any agency I didn't call out, or anybody else that would like just to take a moment to introduce themselves?
Hi, this is Jessie Frenier. I'm the Regional Director for HCR, and we serve adults in Clinton, Essex, Franklin, and Charles County with AHI.
Pleased to meet you as well.
Anybody from the CAT team that would like to introduce themselves?
Hi, Joe. This is Travis Bethel from the adult program for AHI Community Access Team.
Pleased to meet you, Travis.
I'm Kirsten Egge. I'm here representing Essex County Mental Health and Community Services. We have 2 adult care managers who work with individuals in Essex County, and we specialize in behavioral health.
Awesome. Thank you, Kirsten. Well, I appreciate that, guys. It's helpful just to know who's on the call and get a little dialogue going early on in the conversation here. So I'll take myself off video now and continue with the presentation, Ann.
Perfect.
All right, so I want to jump into an overview of the project just to give everybody a feel for what we're trying to accomplish. I do encourage guys questions along the way. We'll pause at the end, certainly for any questions that people may have. But if you have questions, please do not hesitate. Just shout them out and we can address them in real time. So a lot of the focus of the prior work that we did with Ann and team was around planning. And the focus of this scope of work is really around implementation. So the implementation specifically of a business intelligence infrastructure. So first and foremost, our goal is to understand, design, architect, and configure a solution that meets the security requirements of New York State, which we did conceive of when we were doing the SSP work with you guys. But most importantly, enables your performance management goals and supports your operation and your use cases as a network of CMAs. As part of that work, we have to develop and design and implement a data model. We're going to talk about these things in a little bit more detail, but that's how we take information from the sources it currently resides in and put it together in a logical way that lets you ask questions and derive insights from the data. The ETL framework, which is a function of how we get the information from where it's stored to where it needs to be centralized within that Power BI infrastructure. And then the development of reports, dashboards, and analytical models that help answer those questions that help support your business. Part of this is also enabling the AHI team to manage and modify this infrastructure on an ongoing basis. So we're working closely with folks on Ann's team to stay up to speed with what we're doing. They're directly collaborating in the development of requirements and the work, and they will be able to maintain this long-term so that you're not dependent on us forever after. And then finally, working with each of you guys in the CMAs is training relative to the use of the tools and interpreting what they mean and providing you access to the infrastructure once it's developed and deployed. So those are the goals that we're trying to accomplish. This is a high-level overview of the project timeline, so you can get a feel for kind of where we are today. This was as of yesterday, June 21st. Some major milestones to point out. One is, we're working to finalize business requirements. So Ann and team had done a tremendous amount of work in our last scope of work with the team to define the use cases that a business intelligence infrastructure could support. Essentially, what we're doing now is just prioritizing those use cases relative to what we build out and what will be available in reports and dashboards first, and then what the staging will look like thereafter. We are currently on track to have the infrastructure deployed to Ann's team by the 18th of July. And so you can see that second flag up above. So that'll be accessible to the lead health home. And then our intention is for this to go live with you, the CMAs, in the middle of August. And so those are the kind of three major milestones we're working towards. The gray diamonds you see at the top of the timeline represent these sessions that you guys have. I believe you refer to them as office hours. We'll use this as an opportunity to provide education in terms of what we're trying to accomplish and engage with you guys to get your feedback. So that's a big part of the hope for today's meeting. So today is the 22nd. We'll be coming back to you on the 27th and demonstrating the Power BI infrastructure and the and the business intelligence tools. And then we'll be checking in with you on the 24th after we've started deploying the solution and providing training. Along the bottom here, you see approximately a 3-week cadence associated with the white diamonds. This just represents working meetings that we have scheduled for Ann and team. We're in very frequent communication, so we hold these meetings on an as-needed basis, but it's time in all of our schedules to make sure that we're aligning about the project and the work that we're doing. And then at the bottom of the screen here, you see 7 different work streams. So today, we're really going to be focused on that strategic alignment aspect. So this is both the work that we did prior that led to this being a focus area, and as I'd mentioned before, the plan that we had developed and now moving towards implementation, but also making sure that as we build this tool for you guys in the form of a business intelligence infrastructure, that it meets your needs. And we want to think of that first and think of that always, so that whatever we develop and make available to you has as much utility and value as possible to all of you as the stakeholders in the network. Workstream 2 is really focused on a data source analysis. We're going to talk a little bit in some of the future slides about what those data sources are, but this is us getting our hands around everything the state makes available to us, everything that you guys have access to relative to your day-to-day operations through tools like NetSmart, and understanding the quality and consistency of the data contained therein. Workstream 3 is really focused on the development of the Power BI infrastructure. So this is standing up the environment that you guys will ultimately access and log into, putting all of the security requirements around that, populating with data, etc. So that's Workstream 3. Workstream 4 is focused on that ETL, or extraction, transformation, and load process that I referred to earlier, which is how do we get data from the sources listed in Workstream 2 into Power BI, and how do we do that in a consistent mechanism that allows for frequent updates and refresh of the data. So as information change, you guys get to see that as close to real time as possible within the dashboards and reports. The data modeling I alluded to earlier, which is how we collect this information in a logical way that lets us ask questions of it and derive the insights of interest. And then work streams 6 and 7 are really about rolling this out first and foremost to the lead health home and Ann and team, and then ultimately getting this in the hand of you, the end users, and making sure that we deploy it to all of the relevant resources at each of your CMAs. So as you guys can see, this has us wrapping this effort up at the end of September. And again, with that initial go live, which may be staggered, meaning we might roll this out to CMAs sequentially, as opposed to doing everybody at once. We still have more planning to do internally, but that process will start no later than August 15th. So I'll pause there and see if anybody has questions relative to what we're trying to accomplish or the time frame associated with it. All right. So when we think about developing a business intelligence strategy, there's two things that we want to look at. One is the plan, which I had alluded to before, and the second is the infrastructure. So relative to the plan, and this is a concept that we had come up with working with Anne during the SSP project, was we want to be informed by and driven by the use cases that you guys have. And so when we think about your operational and strategic initiatives as care management agencies, we think about the dictates that are being forced upon you by the state. We think about your entree into value-based care, your ability to extend the capabilities you've developed to potentially non-Medicaid populations, et cetera. Right? Those are some of the key things that we want to consider when we think about what does this tool need to do for you guys. That leads to conversations around data use planning. So in order to achieve those operational and strategic goals, what insights do you need to gather from the data that's available to you, and who needs access to that information in order to support the identified use cases? And once we've defined the use cases and our plan or intention for how to use that data, that tells us what we need from an infrastructure perspective, meaning what tools, what security considerations, et cetera, do we have to build in order to realize the data use plan and achieve our use cases. So that's how those three pieces work together. Each of these was considered and accomplished as part of our prior scope of work with Anne and team. And so a concrete example of that is, while Power BI didn't exist the way it does today, or will when we roll it out to you guys, we had considered that in our response to the state and made sure that we contemplated the existence of Power BI in a future state, so that it was part of the approved infrastructure that the state, will allow us to process MCD within. So we wanted to make sure that we did all of that so that what we told the state we were securing and how we were securing it was all going to support your future use cases in business intelligence, as opposed to be a barrier to that. So when we think about use cases, there's kind of 5 pertinent elements that Anne and team considered in the prior scope of work that we went through. First was insights. And when I say insights, I'll talk about that in generic terms. You'll also hear me use the term key performance indicators today. But that's really any metric, measure, analysis, or other point of interest that you want to pull out of your data. So when we think about insights, that's really that's the the quality measure, or again any point of interest that you can build using the raw data that you guys have today. But when we develop insights, we're developing those for a purpose, and that purpose is usually to disseminate those to an audience. So we want to think for each of these use cases, who is this information or insight important to? And that could be individuals or groups of stakeholders that are intended to receive that information. And we're sending that information to them, right? We'll distribute information to you, the CMAs, because we're trying to foster certain actions. And so what response do we want to elicit from you, the stakeholders, when we share data or insights with you? And sharing that data, what's our intended impact? In other words, what's the quantifiable indicator that can be tracked to measure our success? Is giving you guys data and the information you need making a difference? And then finally, that alignment of how does this support our strategic goals or program requirements within this use case? So this is an output and just a sampling of work that Anne and us had done in the prior engagement, which was just to really put all of these things together, identify those insights, audiences, actions, impacts, and their alignment. So, Anne, you can keep me honest here, but I think the inventory is 70 or 80 use cases long at this point, and this is what we're drawing from relative to our prioritization of what we build first within Power BI.
The list is definitely growing, which is exciting for sure. But yeah, we have quite a bit planned.
One thing to note here too, and you'll see this reflected on the next slide and throughout the rest of the presentation, but there's 3 primary groupings that were contemplated when we think about dashboarding or how we put these measures together or these use cases together. Those focused on efficiencies, those focused on process, and those focused on quality. So I just wanted to point that out here, but you'll see that reiterated here on the next slide. So when we think about those insights, one of the common insights that we tend to talk about from a Power BI or a business intelligence perspective in general is this concept of key performance indicators. And so as I had mentioned, what you see listed are the 3 categories that Ann and team have come up with and some examples that would fit into each of these buckets. So when we think about efficiencies, the cost of health home care management per unit of service is a really important thing for us to consider if we were to contemplate participation in a value-based care arrangement as a for instance. And the demonstration by health homes and CMAs that the work that you guys do saves money. That comes from understanding your cost per unit of service and then evaluating your outcomes. Things like billing error rates. So where do we have missed opportunities that could be associated with us billing at the wrong level or not having complete information that would not lead to reimbursement? And then of course, when we think about things like productivity and monthly volumes by each CMA or each care manager, we can start to look across the network and understand where we have opportunities and where we have best practices. On the quality metric sides, this starts to align hopefully with some of what you guys have seen relative to value-based care and what some of the MCOs may be pushing regarding avoidable utilization, which of course was a huge focal area for DSRIP. The HEDIS measures that all payers want to improve and some subset of which are always included in these value-based care contracts, and then closing gaps in care, which is something that you guys do all day, every day. On the process metric side, so we can think about folks having timely completions of assessments and care plans. Those may be initial or updates. We could look at things like referrals that are coming to us from the community or referrals that we're making out to the community at large. And we can also look at things like how often our care managers are engaging with high-risk subpopulations, which would be an indication of increased need, but also increased service, and start to understand how that correlates with things like improved outcomes. So I'll pause there just to see if anybody has any questions relative to what's been presented to date. All right. So when we think about creating a comprehensive approach in a business intelligence plan, we have to think about it in 2 ways. And we talk about it in terms of a right to left approach and a left to right approach. So on the right-hand side, we think about process and performance management. And this aligns with what we had talked earlier about your strategic goals or your operational goals and the use cases you develop and the types of insights that you want to be able to generate. But on the left-hand side, we have to marry that up with infrastructure and data governance. And the infrastructure piece is a nod towards what tools do we have that both capture data, but also allow us to process that data and share that data. And data governance speaks to what's the quality of that information and the impact of point of care documentation practices, and then our ability to use that data in a meaningful way downstream. And data governance, I'm sure you've heard the term before, garbage in, garbage out. That's a nod towards the fact that we're dependent on how each of you enter information in your systems of record or how the state makes data available to us when we want to leverage that as an asset to drive business intelligence. So some driving questions that we have to ask ourselves. We just talked about KPIs, but what KPIs do we need to use in order to measure performance and key processes? Once we have those KPIs, though, we have to break those down into their building blocks and ask ourselves what data or information is needed to generate those identified KPIs. On the left-hand side, if we look at infrastructure and data governance, we have to ask ourselves what systems, tools, and data sets are used to track service delivery and support operations. So, we can think about this in terms of NetSmart, which I mentioned, all the files that come out of the map system from the state and all of the files they may make available to health homes in the future now that you guys have gone through the rigorous security assessment. But just the fact that those tools exist or those data sets exist isn't enough. We really have to understand what information is contained within them and what's the quality of the data. And can we trust that data when we generate the insights of interest on the right-hand side? So from a deliverables perspective or work products that result in this, from our perspective and the work that we do with you guys, we talked already about our intent to build those performance management reports and the analytics within Power BI. The data dictionary is a tool that we're using or building with in concert with Ann's team now, which basically says, okay, how is this measure defined? And then again, what building blocks do we need? And that creates a superset of all of the points of data that we have to collect from all relevant systems. On the left-hand side is this concept of an asset inventory. And then part of the work that's in process now and that I had gone over quickly as part of the timeline review is the data availability and quality analysis. And then ultimately we end up with a gap. And this is important because what we want to do is governed by the data that we have and the quality of that data. And we have to marry those two things up. And that helps inform our prioritization or identify where areas where the gap needs to be closed. And so when we look at what we've done to date, these green check marks just represent all of the work that was accomplished in the prior scope of work. And those boxes that don't have those green check boxes are the things that we're working on developing as part of this statement of work. So I'm going to now switch gears to the infrastructure side of things, but want to pause again to see if folks have any outstanding questions or concerns. All right. So when we think about business intelligence infrastructure, so that was all the plan, and this is focused now on the tools themselves. So one thing we want to think about are data sources, which you've heard me mention a bunch. The flow of information and the mechanisms to share data or insights. So I won't read through all the details on the right-hand side of the screen, and we'll certainly distribute this presentation after our time together today, but want to call out a couple of things. One is USCMAs leverage NetSmart as a transactional tool, right? As you're delivering care management services, you're making updates to records within NetSmart. Those records become accessible to us as a source of information we can draw from when we're building our business intelligence environment. And that's the arrow you see going down to Power BI. There are also sources from the state. So I mentioned MAP earlier, but we can include psyches or data coming directly from the MCOs. Some of that information ends up in NetSmart. When it does end up in NetSmart, we're going to pull it directly from NetSmart. But there is some data that might not end up in NetSmart, and we could take directly from those sources and also bring that into Power BI as well. The other thing to note is we have outside data sources that we're drawing from, including the Health Information Exchange. And that, of course, is based on your treating relationship with a patient. And that information ends up in NetSmart. And then finally, we want to think about, okay, you guys have participated in terms of your data entry. And if we follow the upper left box into NetSmart, that information ends up in Power BI. It's combined with other data sources. We generate those insights, those reports, dashboards, et cetera, and we want to get those back in your hands as CMAs. And so there's two ways we can do that. One is we push data out, meaning we generate a report. We could think about an Excel-based spreadsheet, and that gets distributed to the CMAs. The other option that we're trying to enable and will enable through this work is the pulling of information, meaning we take all that information, we make it available in a central location, and we provide you access to that information, and you're able to reach in and grab that and review it anytime you want, and it's updated on a regular cadence. So that's just that gives you a feel for the kind of various pieces we're considering and how they all fit together. The other thing I had mentioned was that ETL, or extraction, transformation, and loading, which you can see here. So a couple of things to call out. One is it always starts with documentation. So we have to consider the standards, processes, and approaches that drive your documentation standards to ensure that the data has high quality and that it has high fidelity, or that we can trust it. So this is a role that you all play today that you may not have consciously realized, but this is where all of your business intelligence starts, is with your documentation practices within your systems of record. As I had mentioned, that data, as we just showed on the previous slide, most of it lives either in those state provided data files, the MCO data files, or NetSmart. We have to pull it out of those sources, and that's the extraction component. The transformation is to take that data and make it all apples to apples, so it fits neatly within and has a common set of understanding when we put it into a business intelligence tool. So that's the transformation aspect. And then the loading of that data is putting it into the data model that I referenced in the overview slide of the timeline, so that that data now all lives in one place. It's all structured a similar way. It's been standardized, and we can therefore ask questions of the data and trust the outcomes that we get. All right, so I'll pause there again, folks, to see if there's any outstanding questions relative to either the planning component or the infrastructure component. All right. So now we can jump into the aims and drivers. And this is, again, the work that was reflected in that strategic alignment work stream, or work stream 1. So just to introduce the aims and drivers framework. So what is it? It's an approach that we can take, as I had mentioned, to establish goals, also referred to as aims, and then identify relationships, or those things that enable us to achieve our goals and our aims. It's also a tool that we used often in our practice to create a shared vision for the factors that contribute to the achievement of collective goals. And given that you guys are a network, that you do have a set of collective goals that you're trying to achieve, we like to apply this framework just to put all the pieces together in a way that everybody can follow and see how they impact where you're headed and what you're trying to accomplish. Just a couple of definitions, just to ground us before we provide you with examples and talk to you about how we're using this in your specific application. So the last slide, I had talked about goals and those specific aims. We can also think about those in terms of project or projects that we're trying to achieve. Those projects could roll up to a broader global aim, which is kind of the overarching objective or strategic intent. We can also think about that sometimes in terms of mission or values. And then how do we decompose that into a set of projects or goals or those specific aims? Primary drivers, which you often will hear referred to as outcomes, are all the concepts that we need to be addressed in order to achieve your aim. So again, it's a component of an aim. Secondary drivers, which are interventions, are subcomponents of primary drivers. And we can think about those in terms of process changes or things that we need to address that are necessary and collectively sufficient to achieve the aim. So a global aim has specific aims, a specific aim has one or more primary drivers, and a primary driver has one or more secondary drivers. The last piece of this is change ideas. And this is ideas that you'd like to test in order to accomplish your secondary drivers and impact your primary drivers and your specific aims. Now, what we always do when we apply this concept to business intelligence projects is we're talking about the measures, metrics, KPIs, and insights that we want to develop that will support your secondary drivers and allow you to track those and know that you're making a difference and that the things you're trying to accomplish are working. So you'll see these change ideas reflected as the measures themselves. So the aim that we came up with in collaboration with Anne was ensuring care managers provide high quality, efficient service to clients. When we think about that as a concept or a goal, there's a couple of things from a primary driver perspective that will support that. One is to make sure that we're managing the caseloads for each of the care managers. And the other is that we're providing direction and developing standards relative to documentation processes and timelines. So what activities should occur at what points in time? So now we can take that one step further and say, okay, we understand our aim. We understand that these primary drivers impact our aim. How do we actually accomplish those primary drivers? So from a secondary driver's perspective, when we look at management of care manager caseloads, We have to establish and monitor benchmarks for caseloads. So how do we know that people have the right amount of members that they're serving, but not too many? And then the other piece here is establishing and monitoring benchmarks for client throughput. So we'll talk about this in more detail. I think it'll make more sense, excuse me, when we look at the actual measures, but how many patients do we have that are not enrolled that could be? How many patients do we have that may be disenrolled or disengaged? And how will that change the balance of the number of members that each case manager or care manager is serving? When we look at standardized documentation processes and timelines, so some secondary drivers for that. One is on-time completion of assessments, which I know is true to the work you guys do every day. We can also think about on-time completion and updates for care plans. And then finally, this notion of establishing and monitoring standards for key information. And you'll see this in the next slide, but that would refer to things like consent. So any questions from folks relative to the relationship between these secondary drivers, these primary drivers, and the aim? Does that resonate with you guys? And does that make sense to everybody? All right, so let's take this a step further and look at how this relates directly to the business intelligence infrastructure and tools that we are building for you guys now. Now, one thing to note here quickly is just these are all causal, right? So unless we do these things to the furthest right of the diagram, we won't be able to accomplish the things in the middle of the diagram, and we won't be able to accomplish our goals. So this is just taking a large goal again and breaking it down into its component parts. All right, so for this next view, what we're doing is we're starting, and just to toggle back to the prior slide quick, we've taken the aim out of the picture, and we're going to go right from primary driver to secondary driver, and then from secondary driver to KPIs or insights. So on the furthest right-hand side, these are all of the insights. Again, the measures, metrics, or points of interest that we want to derive from your data. You can see a key at the top right-hand of the screen, and the color coding just to indicate whether or not that falls in the process bucket, the quality bucket, or the efficiency bucket. And again, these are change ideas or things that we can implement in order to understand if we're making a difference. And in this case, the change idea is to provide you guys with this insight through a business intelligence tool on a regular basis that's updated. But when we think about establishing and monitoring benchmarks for caseloads, that really resolves to caseload ratio points, which is a concept I know you're all familiar with, but making that highly visible and highly accessible to you. When we think about establishing and monitoring benchmarks for client throughput, there's a couple of different concepts here. One is rate of enrollment growth. So how are you as a network, but also as individual CMAs, growing your enrollment over time? A proxy for that certainly is also how revenue is growing over time. So when we think about the number of billable activities, we can also think about things like designations such as Health Home Plus, and how many eligible members do you have that are Health Home Plus eligible but not currently enrolled? And then finally, we can look at where do we risk losing members, and that could be either because they're have a low rate code designation, and we can look at that in terms of percentages or total enrollments. We can also look at the number of members that are falling into that diligent search category and may, if we're not able to re-engage them, lead to a decrease in our membership, all of which, of course, will affect the care manager caseloads. So going to our second example, or our secondary primary driver. So standardized documentation processes and timelines. So we talked about on-time completion of assessments. Well, how can we measure that? Well, one is what the number of comprehensive assessment amendments due within 10 business days. Now, 10 business days is an arbitrary time frame. That could be any amount of time that we think is most appropriate. We could also look at initial comprehensive assessments, or we could also look at home and community-based services eligibility assessments. On the on-time completion or updates for care plans, we can think about the number of care plan amendments due within 10 days, or the number of initial care plans due within 10 days. And then, as I had mentioned earlier, when we think about establishing and monitoring documentation standards for key information, we could look at things like the status of case notes, the percent of patients that have verbal but no written consent on file. And we could also think the percent of patient panel with missed billing opportunities. So where had we delivered a service, but we didn't have our documentation done in a way that would allow us to maximize that opportunity and to realize that revenue. So any questions, comments, or concerns from folks relative to the way these measures have been laid out and their relation to the secondary and primary drivers? Just one thing to note is that this inventory of measures and their alignment with secondary and primary drivers will grow over time. So there are 16 measures, I believe, between these two that have been defined to date and prioritized by Ann and team with the assistance of our team. As this grows, and the next slate is the value-based care measures, we will extend this model, this aims and drivers framework, to incorporate those as well and make sure that we provide you with an update as it's available. So one thing to note is we just went through the list of all of those measures. We have different ways to slice and dice this information. One way is how we aggregate that data. So there's a couple of things to consider here. We have everything at the network level, so we can look at what is our performance on any of those measures across the entire network. When we think about the users that might relate to, this would be administrative staff that work for the lead health home that are supporting Ann, and they may be interested in looking at performance across the entire network. But we can drill down a level. And so when we look at the CMAs, we could look at CMA 1 or CMA 2, and that can go on to as many CMAs as that we have. And we can aggregate the data that's just relevant to them. And so when we think about users that might be interested in this level of access, these would be the managers or directors at each of the CMAs that are overseeing the operation within that organization. Below CMAs, we have the supervisors. So we could aggregate data at this level and provide them with access to information. We know supervisors may have one or more care managers that they oversee and that report to them. And then on the last level, we can look at the care manager level. And so the important thing about this is, A, there are walls between each of the CMAs, and that'll be consistent with how information is reported and presented to you guys. And that based on your role in the organization, we can provide you with the appropriate level of access by only considering data that you should have access to if you're a care manager, a supervisor with a relationship with multiple care managers, or a director or manager of the CMA that's interested and should have access to everything. The other point of consideration is timeframes. So one of the things just to mention is that when I presented those measures, other than the example of the due within 10 days, those are not bound to a definition of time. The reason for that is that these tools allow us to dynamically look at measures across different timeframes. And so what you can see depicted on the bottom of the screen are some classic examples that we tend to see. So if we start at the top and we look at the white diamonds, we may want to compare two different reference periods. So how are we doing on that measure from April 1st to July 1st of 2020? And how does that compare to our performance for July 1st to September 30th? And look at those side by side. That's one option that the tools afford us. We could look at things like year to date. So when we think about year to date, that's from January 1 to, in this example, we'll pretend that this is May 1st. So we are only interested in looking at data for the first 4 months of the year. We could look at the last year, meaning the last calendar year. So that would be December 31st of 2020 to January 1st of 2020. And we could look at things on a rolling 12-month basis, meaning 12 months from today. So in our example, it was May 1st, that would be April 30th to May 1st. So this just gives you different ideas of how we can look at those measures and the different timeframes associated with those. So in terms of next steps, I just wanted to revisit this diagram quickly. So As a reminder, on the meeting on the 27th, we'll be showing you guys this in action. So at that point, all the concept and kind of, what we're hoping today is to set expectations about what you will see. And then on the 27th, we're actually going to demonstrate and show you that. So that'll be the next time we get together, and that'll be the primary focus of our time together at that point. So I'll pause there. That's all the content that we had to share, and just get anybody's questions, comments, or feedback.
We have a very, very quiet group today. This is not the norm, I must say.
Hopefully I didn't scare you guys off.
And I'm just, it was coming to me. This information is a lot like what Taylor's giving us currently.
Yeah,
Right?
it's a lot of what we've worked on so far, but then really the expansion into all of the use cases that we haven't published in any way, shape, or form yet. So it's like taking what you're currently getting and putting it, like, use a car analogy. Like right now you can only see the glove box, but once the infrastructure is up and running, it'll be like, yeah, you're taking a ride in the whole Cadillac, if that is a good analogy. And kind of in the spirit of that, the one thing I did want to mention is that when you or your care managers have ideas for insights or information that you would like to see or you think would be helpful in your day-to-day operations, please send those our way. Every bit of feedback that we get from all of you really helps to support the use cases that we have inventoried thus far, and it will only help kind of, sharpen the saw and make this a better tool for you come September.
Now, is this just going to be for managers, or will case managers have access to these reports?
Super glad you asked that question. One of the I would say unique pieces of our plan, and one of the things that I think is most exciting about the plan, is that we really tried to identify a tool that would enable access to every care manager in our network if that was your choice. So you as an agency might say, well, maybe I don't want to give access to every care manager, but our intention was to build it in such a way that every care manager would be able to see their information for their patients, their members, so that currently you have to kind of rely on a supervisor or a manager to kind of collate information and then kind of ship that information out to different care managers. This would take some of that responsibility off the care manager, although they'll still have oversight. They won't have to go to that manual effort to kind of aggregate the information and then send it out to each care manager.
I have a follow-up question. So, and I might have missed it. It was a lot of information. So is this going to be a separate program than NetSmart, or is it going to be combined?
It will be a separate system. It will not be contained right within NetSmart.
Okay, thank you.
And we had, for sake of use or the ease of use, we had approached NetSmart about being able to leverage your NetSmart credentials to log into this directly. Unfortunately, that's not an option that NetSmart supports today, but we did try for you guys.
And certainly, you never know. I mean, just because, their answer was, well, we're not quite ready to do that yet, but that doesn't mean that, there's some potential in the future, and we will certainly keep pursuing that. With the end game being ease of access for all of you and for the care managers. Any other questions, concerns, feedback?
Joe, really looking forward to seeing the demonstration on the 27th, to see the information, how it flows, and the visual of how that will look.
Appreciate that, Travis. We're looking forward to that as well. I think it'll help really solidify a lot of this concept, and a picture is always worth 1,000 words, right? So to see it in action, I think will help clarify.
Absolutely.
Okay, any closing thoughts, Joe and team?
No, just appreciate the opportunity to work with you guys and all the collaboration from, Ann and team. I know Taylor and Tazeen and others have spent a lot of time working with us to get this right. And, I truly believe in this being hugely impactful to the work that you guys do and making it a lot easier to do your jobs. And so we're excited to support you in that way.
Thanks so much. We're super excited too. So we will let Joe and his team drop off the call. I think, Travis, you have some agenda items that you wanted to go through for the remainder of our time today.
Yes. Joe, thank you again to you and your team. And appreciate you coming on today to present.
I have another question, Travis. How quickly will this recording be put up? Just because that was a lot of information to revisit before next meeting is what I'm thinking.
Yes, we're hoping to get this up as soon as possible. We've had a transition on the staff that was posting stuff on our HI website for us, so that's caused a little bit of a delay, but our intent is to get this recording up as soon as we can. I know that doesn't give you a specific date, unfortunately, but we're aiming to get this up shortly. Is there any other thoughts or questions around that presentation?
I'm just going to say, I know that was a lot of information and a lot of technical information, and you all know I'm a tremendous data geek, so all of this is very exciting to me. I felt like it was important that we shared the concepts as they relate to how and why we're going about the work. And I think that the exciting items and the actual visuals will be probably a little bit easier to digest. But I really appreciate everybody kind of sticking with us today and kind of listening to some of the the whys and the whats, and it'll be exciting to get to the how we're going to do what we do next month. So really appreciate everybody's time. I know it's not the most exciting content, so I totally get it.
Well, it gives the why behind when the visual does come up, just so people had a little bit of a backdrop. And this will be a reference for folks as well. The slide deck will include Joe's presentation today as well, so people can look through that again as a reference. So there's a few other topics today. I know we've been on for just under an hour here, so we won't be too awful much longer. But I just want to take some time to touch on policy and procedure updates. Since we last met, I had sent out to the network the updated transfer policy for adults and children, the Health Home Plus SMI and AOT for adults, a non-health home policy for adults and children, and then we have a new children's policy initiating and maintaining OPWDD ICF level 2 LCED policy, which is a mouthful. But just wanted to make sure folks got those policies. If there's any questions anybody wanted to ask today around those 4 policies. I am starting to, as I indicated in our last office hours, to do a little summary with each of the updates when they are sent out, just to help folks get the snapshot of what the changes are. But again, we ask that folks read through the policy so that you're up on the full policy itself and have an ability to ask questions. And then we have upcoming, we're working on finalizing our disenrollment step-down policy. I was just working with MAP and NetSmart, our data team's looking to get the codes from MAP into MAP, and then as NetSmart as well, so that we can roll that policy out to the network, because there are 3 step-down codes that are new that will be available for folks when we look towards disenrollment for members. And then finally, a systems access and training requirement policy, which has gone a number of revisions before our final review, but that's in progress as well. But I just wanted to pause to see if anybody had any questions on any of the updated policy and procedures to date. Okay, well, if you do, please reach out to the Health Home email and we'll answer your questions for you. Jessica, I was going to reach out to you in regards to the Health Home Serving Children and HCBS audit update.
Hi, everyone. Just a quick update on our HCBS audit. I wanted to let everyone know that year 2 is scheduled to begin on 7/6. That is when we have our entrance conference. And year 2 will be covering April of 2020 to 3/31 of 2021. We also have received our year 1 feedback from DOH. I have followed up with some CMAs only regarding the PCP follow-up for all of you. So please work with your members and families to get those scheduled. I'm also going to be working and incorporating some of the auditor's feedback into our upcoming plan of care training, our HCBS training, and some updated policy. Unfortunately, in the detailed feedback from the state on the scorecard, it did not go by member. So I don't have individual feedback on each scorecard for each specific member. So member A was missing this information. It was just, you had 6 out of 10 members missing this information. So the only detailed I had was on those PCP visits, but overall there was themes that we are able to look at and update some trainings for you guys and policy. So that will be forthcoming. I am currently working on it. Hopefully in the next month or so, we will have an updated HCBS training, updated policy, and a network plan of care training for adults and children. Does anyone have any questions?
Jessica, are you able to just give folks a sense, like overall, how it went?
Yep. So last month on last office hours, I went over the high level overview. I don't know where we compare to other children's health homes. Like, I don't have a sense of how we scored compared to everybody else. I'm always disappointed in how we do, always. So I can't say like, oh, we didn't do well, because we might have done really well and it's just not good enough for me because I'm an overachiever. I think though, from what I'm hearing from other children's health homes, is that the common themes that in the areas that they're finding in this audit are common amongst every health home. It's not just us. So if we got hit in one area, it seems like every other health home also took notes in those areas. So overall, it was detailed notes we need to work on, HCBS disenrollment, our HCBS plan of care, our forms not just being present in the chart, but also making sure that they're filled out completely and accurately. Those were the overall themes. I think it's all stuff that could easily be corrected with some updated policy and training. And then today I also did get the list, the case list from the state, and the amount of cases being audited for year 2 is much smaller than year 1. And none of them include the transition youth, which was a difficult population as is. So I already anticipate doing much better on round 2. And I think most agencies only had maybe 1 or 2 people selected for audit. So I will reach out individually to each agency. So like Lori, I'll let you know that who got pulled, just so you guys can look at the chart. I'll look at the chart, and then any missing documentation we can get uploaded.
Thanks, Jessica.
You're welcome.
Yeah, I think Jessica already mentioned this, but I think I'm gonna say it again, because I've heard it on a couple of calls with the state, that across the state, one of the quality metrics that they found is lacking was well child visits. Is that accurate, Jessica? Just to keep me honest.
Yes, so it was out of the youth enrolled in HCBS, how many of those youth have had a well child visit in the last year? And that was across the state. Statewide, we scored under 50%, and I believe the threshold was 85 is what we're supposed to be at. So they did send us those member level details on which members of ours did need a child well visit. And those were sent out yesterday, I believe.
Yeah, I think that, I mean, when we think about gaps in care and our quality metrics, I feel like there's those metrics that we can more easily impact than others. And this is one that I feel like there's a lot of opportunity for improvement, just because, we have a pretty rich primary care network in our region. Fortunately, for such a rural area, we're kind of blessed that we have that. So I think, it depends on, which way you'd like to look at it. I'd like to look at it as well. This is a great opportunity for improvement. This should be a metric that we can definitely move the needle on without tremendous gaps, if you will. So I think that was actually helpful feedback from the state.
Yeah, I agree, especially because a lot of, I don't want to say a lot of our members, but our members who are fee for service right now, the only data we get on gaps in care come from our managed care company. So if we have a member who's fee for service, we're not getting that information like, hey, this person's due for this. So that was helpful for them to give us that information on youth that we wouldn't otherwise know. And I actually spoke to someone from Citizen Advocates today, and they already have their members scheduled for their PCP visit. So as soon as you guys do get that information, you guys do make it actionable. It's just getting our hands on that information and then doing the follow-up.
Which ties in nicely to all the technical stuff we just talked about, because future state, we want to be able to give you that information to say, here are your members that need a primary care for your adults and your kids, right?
That was a good plug, Ann.
Right, all right, I'll be quiet now.
Anybody have any other questions or thoughts around the Children's HCBS audit? Jessica, thank you. Thank you, Ann.
You're welcome. And like I said, I just got the case list today and I was just going through it. So I will be reaching out individually to let each agency know who of their members got pulled.
Okay, thank you. So next thing I want to talk about quickly is HCSCN report request errors. I know there's been issues receiving HCSCN reports in the system through NetSmart. One of the things that we want to make sure folks have is what they need to provide us so that we can provide it to NetSmart. And it's on a case-by-case basis that we need this for each person that you would be looking to get information on the HCSCN report. So that would be their client ID, a screenshot of the type of error, which has been pretty much a generic error coming through. The day of the emergency room or inpatient admission that it happened, if you knew that. And then what location type, so the hospital or what facility. And we're asking that that's sent to the health home email, and we're getting that information, and we're working with NetSmart to try and get that ironed out, because it has been a touch and go area for folks. You should all have the ability to have access to request a CCD for HCSCN report. So, we're working on it, and just please provide this information that will help. So that's for HCSCN.
Hey, Travis.
Yes.
Can you hear me? Hi.
Yes.
Just to go the Hixney, one thing that we discovered internally, because we had two youth of ours actually go inpatient and we didn't get the Hixney alert for, so we believed at first it was a Hixney error. We later found out that it was actually an error in our workflow, that when you have a member, you have to do your client search note that enrolls the member in Health Home first, and then go in and do the Hixney consent. If you're going into the chart, you have a new member and you want to, click on their Hixney toggle first and then go do your client search note that enrolls them, that actually will not turn on your Hixney consent and you will not receive alerts. You have to do your client search note first, get them enrolled, and then go enter your consents. I just wanted to point that out because that was, at first I thought we were having issues with Hixney, and then we later found out that it was actually, we had a workflow issue. So I don't know if that could also be causing some of the other CMA issues.
No, that's good information to have, and it's another, avenue people can look at first before they reach out in regards to, an error, if in fact there is a workflow concern. So thank you for pointing that out, Jessica.
Just as a side note to that, we are working with NetSmart as far as that logic being flawed. We would like NetSmart to recognize the Hixney consent as soon as the care manager toggles that to yes, because that would indicate that there was a consent and the consent triggers enrollment. So there will definitely be more to come related to that as we have further discussions with our vendor.
Excellent. So,
hi Travis, this is Taylor. I just wanted to say we did receive word from Hixney. We've been talking to them regarding this earlier today, that the issue should be resolved now. But definitely continue to send any issues you may have to the Health Home email. That way we can touch base with them if for some reason it's still not working appropriately.
that's wonderful progress. We love to hear progress, especially since the slide deck was put together. We love it. Great. Well, let's keep our fingers crossed. Thank you for that update, Taylor. Anybody have anything else around Hixney report? Okay. So I just wanted to bring this up again because, we had talked about it last month and it was the first time we had brought it up in a couple months, but I just want to touch on the written consent, post-verbal consent. The pandemic, DOH at some point is going to be rolling back that waiver. I don't have a date at this point, but I can't imagine it's too awful far off in the horizon. So I just want to make sure folks are getting those written signatures, those electronic signatures as soon as possible. That 60-day time frame window is allowed at this point, but that's not going to be forever. And it's got to be documented that the consent was obtained once it was obtained. So just bring this up again as a reminder. I know folks are working diligently toward this and have been, but I'm just trying to be proactive. The Health Home's trying to be proactive for when that time comes and that rollback on the waiver happens, that we're not in a situation where we have a mass number of folks out there that have just verbal and they've lapsed 60 days. And, I just want to avoid that cluster, if you will, from occurring, or minimize it as much as we possibly can. So please do your due diligence as always, and just try and get those folks to get those written consents as soon as you can after enrollment. Is there any questions around that? I know we've been talking about it off and on for months, but I think the clock's ticking at this point. Okay. The next thing, I'm gonna cast a poll out. We're just curious as a Health Home about the Unitas platform and ADK Wellness, if a lot of organizations in our network are using it. And if so, we were looking to see who was, and people are using it for Health Home referral. So I'm just going to shoot out a poll here. If folks wouldn't mind taking a second to answer yes or no. And here comes the poll.
And just to be like super clear, only answer yes if you are using it for your health home business. I know a lot of you have other lines of business. I mean, the majority of CMAs do. We just want to get an understanding of if you are using it for health home members in any way, shape, or form.
Yep. So the question is, does your care management agency use ADK Wellness Platform for health home referrals? So that's we're asking specifically to health home referrals. So we have 55%, 60% of folks have voted. We'll let it get up around 70, and then we'll shut the poll out. So I think, what is it? Anything? Oh, 72. All right. 74. All right. So I'm going to end the polling at this point. We had 74% voted, and 19% have said yes. 81% have said no. So I really appreciate that, and sharing that with everybody now so you can see that. All right, thank you for taking time to answer that. The next thing I just wanted to let folks know is we are going to be putting out a plan of care training. It's projected to be in July. Jessica and I have been working closely together to finalize that. And we'll be sending out, we're going to be doing training modules, which will break out in various topics for that training and have them put up on the HI Health Home Trainings page so that folks can access them and select certain topics itself. And so that's coming. I know we've talked about that off and on for a while, but we've had a lot of changes around the plan of care process and some other things that have come up in recent months in the health home. But we are getting to the point here where we're going to get that up and going. So stay tuned. It's going to be coming your way shortly. I didn't know if anybody had any questions or anything.
I have a question, and I'm not sure, hopefully I can explain it correctly. So we get reports of people who are eligible for Health Home Plus, but what we're noticing is that people who have declined services are still showing up with that report. So is there a way that those reports cannot have those people or have those people count against us?
So folks are signing up if they've declined when you've offered that level of support and they've declined, but they're showing up on reports that we're sending out. Am I hearing that correctly?
Yes, and so we don't want those people counted against us.
Right. I refer that back to our.
I can speak to that, Travis.
Okay.
Those percentages that we're sending out to you guys, you don't have to worry about those. We're not really taking those into account. They're just kind of, we're trying to use the same metrics that OMH is using to determine the percentages, but don't worry that those are counting against you. I would just disregard those members from the list if you've already spoken to them and they're not interested in Health Home Plus.
Okay, thank you.
Just one clarifying question. Are these members that you had an outreach and they have opted out? Just so we can, maybe there's something we can look for in the data to help beat some of these folks out.
Or it could be people who are currently on the caseload and, they got that next hospitalization and they just don't want that level of care.
Okay. All right. Perfect. Then absolutely what Taylor said is 100% spot on. They would appropriately appear and just use the list as a tool to ask, your staff, have we considered these folks for Health Home Plus? And just we're trying to make sure that you don't miss the opportunity to serve folks at the Health Home Plus level if they're eligible.
This is Jessica Casey. I just have one more question about the patients identified as Health Home Plus. We recently had somebody that was flagged for Health Home Plus eligible, but we couldn't really figure out in psyches why. It was almost like they may have qualified 6 months ago because of utilization, but the utilization was old. Is there a way, is there someone that we contact to have a flag removed, or is that an option or available to us?
Sheila, yes, that is a good question.
I can
Are
take
you
that.
aware of a process we could go if that were to come up to be the case? 'Cause I think that does come up from time to time. You know,
I was gonna ask the same thing, because we have some that are, you know, stating that they're Health Home Plus eligible, and we're not seeing why or where, you know, it's expired and, you know, they don't require that level of care. You know what I mean? So
So
I've seen it quite a bit too.
this is Jessica. So I have noticed in the psyche's data before that there is a lag in the data, and sometimes there is inappropriate quality flags placed on charts. What I would do is I would send that information to the health home, let one of us get in there and be a second set of eyes. If we confirm that, yes, it is a data error, we can then forward it to the psyche's department. I have done that before. They'll take a look at it and they'll be like, oh yeah, there's something wrong with our algorithm, and they'll take it down. So if you have those people, send it to the health home and we will take a look and we can report the potential error to the psyche's team.
yeah, because that does come up from time to time. I've actually had it come up for our internal CMA. So yeah, just funnel it through and we'll look at that. Thank you, Jessica. Great
Thank you,
question.
Jessica.
Any other questions? Anything anybody wanted to bring up or talk about? Well, thank you for hanging in there today. It was a very long office hours, but we really appreciate your time. I think when you see Power BI in action, a lot of this will start to come together a little bit more for folks, because it was a lot of information, but definitely necessary to review to give the why behind it. But thank you all again for all you do, and I hope you enjoy the rest of your day, and appreciate you joining us today. Take care, everybody.
Thanks, guys.
Thanks, everybody.
Thanks, everyone.